Let me just start over. Okay. This is Dr. Sharon Elliott Bynam, who is the Executive Director of CARE, Healing with Care Incorporated, which is located at 214 Broadway Street, Durham, North Carolina, 27701. Dr. Elliott's focus is going to be around access to care for patients with HIV and AIDS, which is one of the many services that her center provides. But for today's purposes, we will talk about how she and her staff provide services to the uninsured patients who have HIV and AIDS. Dr. Bynam, share with us what some of the barriers are. Or first, share with us what type of services you provide at CARE for patients with AIDS. And also, if you could just then elaborate on some of the barriers.
Hi, Gloria. Thank you for having me, and I'm so excited about sharing this information. Because for most of you, if you're aware, HIV has been around probably on the scene since 1981. Healing with Care was incorporated in 1995, and at that time we were just beginning to see HIV emerge in the African American community. And some of the things that we noticed were lack of education on the part of providers and caregivers in terms of taking care of people with the virus. And so as a nurse, I was concerned about that lack of education, and at that time I was director of nursing, so I took it upon myself to try at that time to educate them on universal precautions and how HIV was transmitted, which we know is only transmitted through bodily fluids and through sexual contact, and also transmitted through a mother's milk or by IV, which means that if there's a needle stick to a provider, then there is a possibility that that person could be exposed. But other than that, we can care for our clients. So I was really concerned at the response that we were getting. So we started Healing with Care just as an education outreach project. We wanted to go into high-risk neighborhoods. And when I say high-risk, I mean neighborhoods where there was a large amount of drug activity going on, a large amount of activity where you had people not working and things going on that possibly led to other behaviors. And so we went into those communities and we just knocked on doors. And we asked the women of the house, do you know anything about HIV? And astoundingly, a lot of people just had not even heard about what it was. So we then started to do education sessions. With the women, we did kitchen table sessions. With the men, we had to get them around the basketball court. So we would do 3-on-1 basketball tournaments, and then during the break, we would talk about condom use and other things. So as a result of that, the education was permeated into areas that were high risk. What we did not count on was the response. Some of the individuals that we educated then sought us out and said, you know, I was really listening to what you were saying, and I think I have a family member that might have been exposed. So then we go into testing. And at the time, in 1995, the only place that was testing for HIV was the health department. Now the barrier with that was there was one location at the health department that had STD testing, and individuals looked at the stigma and they said, if people see us in this area, then they know that we're here to get tested for STD. And so what we did, instead of them experiencing the stigma, we would go with them and sit with them. But then the other barrier to that was a lot of people don't want to necessarily get stuck. And at that time, that same time, what came out was the OraQuick, which is the oral swab to test for HIV. So we were one of the first community-based organizations who was able to get training to do that testing. That meant that the individual in 20 minutes would know what their status was. So when we did that, it eliminated some of those barriers of stigma, some of the barriers of fear, of pain from the needle stick. And so we collaborated with the health department. So any individual that we found to be positive, we would then take them to the health department for confirmatory. But in dealing with this population, what we acknowledged was that there were certain social determinants of poor health outcomes that were just really emerging. And so we said to them, what is it that we can help you with? They were saying when they found out their status, people were putting them out of their house, which meant that they were becoming homeless as a result of their diagnoses. And so homelessness is a huge barrier. And so we started then helping them with that. And then we noticed too that if they were going to be a productive member of the household, they needed to bring something to the household if they were allowed to stay. So we opened a food pantry so that they would have access to food. Because with Maslow's hierarchy, you know, those lower level needs are essential for a person to even get to safety and self-actualization, which is where we want them to be. And so we work with them, and when we work with them, that was called case management. So there was the beginning of our case management, and today, in 2012, we still do HIV case management. We currently have 5 case managers who work with specifically HIV clients. And then other things came out like lack of socialization, because like into the Bible with lepers, HIV was looked at as a disease where people didn't really socialize. They were afraid to disclose because of the stigma that people have with that. So we formulated one of the first support groups, and that support group is still ongoing today, and that's for women. It's called PAW, and we're really excited about that. Okay. But in terms of advocacy, one of the things I want to tell you about specifically that happened just 2 years ago, the legislative, if you know, changed from Democratic to Republican. And so obviously the Republicans aren't looking at social needs as much as maybe the Democrats. So they came on board and decided they were going to get rid of HIV case management. And so we, as an agency, along with other agencies that provided that, had to go to the legislator and educate them on case management of HIV clients. It's nothing like any other chronic disease. When you case manage HIV, you're talking about stigma, you're talking about shame, you're not talking about them getting support like somebody with diabetes or somebody with a heart disease or even somebody with cancer. You're talking about family members turning their back on them. You're talking about lack of being able to get a job, which means that they're not employable, which means that they can't provide for themselves. You're talking about a lifelong illness that you have to take medications every day. You're talking about a disease that has no cure. So these are all the things that we had to educate the legislators on and told them the barriers that we were experiencing and being case managers to people living with the virus. And so we were able to get them to turn that around, and they implemented HIV case management. So today they're still doing it, and what they did limit the amount of hours that we can give them, but it's okay because we are still able to serve that population.
Okay. Outstanding example of advocacy at work. Thank you so much, Dr. Elliott, for your time. Signing off.